under control.
Okay. Still blackout at night?
No, not yesterday. There was no blackout. Day before yesterday, it was blackout.
Okay.
Yesterday night, it was comfortable.
Okay.
But, still they haven't opened the airports. Only one flight went yesterday, probably. And today, 2 people had
I
come
think
from
again it
airport
has been
at
closed.
Pakistan.
है ना Sudha?
Yes, it has been shut again because earlier they had closed it, but then, again they have closed it. Now, yesterday, one flight has gone.
Okay.
And let's see what happens. Hoping for the best.
Yes, yes. हो जाएगा सब अच्छा.
अच्छा होना चाहिए, दोनों साइड के लिए अच्छा है.
हाँ वही ना.
Yes, war is never good.
War is never good. Hi, Shobha.
Sobha wants to join by 2 devices. Rama madam has also joined.
Yes, Dr. Rama, Dr. Duru.
Duru, yeah.
Dr.
Hi, Ragini.
Ragini is here.
Hi,
Hi,
Ragi.
Shobha.
Hello.
Congratulations, Reena ji.
Thank you.
कितने मिनट रह गया? परेश जी ज्वाइन कर रखा है ना आपने? आज के सूत्रधार आप ही हो.
किसको? परेश को बोल रही है?
आज के सूत्रधार तो वही है ना.
Anita, who is going to speak today? आज कौन बोल रहा है?
आज का प्रोग्राम ये अगले की
Hi,
सबसे
Revati.
पहले मैं वेलकम करूंगी, फिर अनीता जी प्रेसिडेंशियल वो करेंगी और उसके बाद टॉक में एक स्टार्टिंग अनीता जी की टॉक है, फिर ब्लेसिंग्स होगी, फिर अनीता जी की टॉक है, फिर मेरी टॉक है. सब छोटे छोटे 10-10 मिनट 10-10 मिनट. फिर शोभा प्रिस्क्रिप्शन बनाएगी और रीना जी जो है कमेंट करेंगे उसके बाद थोड़ा सा, और फिर डिस्कशन होगा.
ऐसा मैसेज मैंने नहीं देखा कहीं है.
ये अभी आया नहीं है क्योंकि ये फ्लो बाद में बना था, तब तक हमारा
अच्छा.
अगली बार अभी कल बना लेंगे.
मुझे लगा मैंने मिस किया.
हाँ, कल बना लेंगे, परसों से निकाल देंगे. अभी भी आपकी पहला प्रोग्राम है, बिना फ्लो के भी हर कोई आना चाहता है.
आ गए हैं.
हाँ.
हाय, गुड इवनिंग ऑल.
नमस्ते डॉक्टर
Hi, Revati.
रेवती, तो कैसे हैं?
हाय
इवनिंग रेवती मैडम.
हाय, गुड इवनिंग, गुड इवनिंग.
ये थी मैडम तो अपनी छोटी
आपकी ग्रैंड डॉटर है क्या?
हेलो. या
Who has written that slogan?
yes, one of our slogan.
Yeah.
Yeah, hello everyone. I have joined now. Good evening. Yeah, good evening, Duru ma'am, Rama Vaidya ma'am. Hello, Anita. Good evening
Hi.
to you.
Good
Ragini.
evening.
Good evening. Sudha.
शोभा
Hi,
दो
नमस्ते.
जगह कैसे मिलेगी?
हाँ, वो
बहुत
मेरा
टाइट कर रखी है.
थोड़ा कंप्यूटर का ऑडियो उतना ठीक नहीं है, इसीलिए मुझे
एक ही खोल पाओगे आप, 2 जगह नहीं मिल पाएगी आप.
हाँ नहीं हो पाएगा तो मुश्किल है, क्योंकि मुझे यहाँ पे
नमस्कार डॉक्टर रमा वैद्य.
हेलो.
मैम.
नमस्ते
रमा मैडम.
नमस्कार.
हेलो शांति जी.
रमा मैम, गुड इवनिंग.
Good evening. Good evening.
परेश 3 minutes to go. परेश यूट्यूब चला गया सबको? परेश जी?
Hello, Paresh.
परेश जी यूट्यूब लिंक चला गया? परेश जी खुद कहाँ हैं?
रागिनी भेज दिया उसने, यूट्यूब लिंक सबको भेज दिया।
अभी शुरू कर रहा है? कहाँ वो?
हम्म।
वो है कहाँ?
है ना, यही तो है।
यार वो तो अब हम लोग खुद ही शुरू कर सकते हैं. He has opened everything. Although very few participants are there yet. 100 में से सिर्फ 70 आए हैं. हेलो, वेलकम मैडम, गुड टू सी यू आफ्टर सो मेनी टाइम्स. तब देखा था बहुत
Oh,
बहुत दिनों बाद.
we met me,
सुरुक्षा मैडम,
madam in
सुरुक्षा मैडम.
Kanpur. No, Ragini, you are
अरे
forgetting.
अबे आपको मालूम नहीं है मैडम के कितने बड़े एडमायरर हैं.
Good evening, Duru madam.
मैडम को लगता है आवाज नहीं आ रही हम लोगों की.
आवाज नहीं जा रही है.
हाँ,
Good evening, Dr. Duru.
आवाज नहीं आ रही है.
I don't.
Hi everyone.
Yeah, yeah. Hi.
Hello,
Good
hello.
Hello.
evening. Good evening.
Good evening,
वेलकम
ma'am.
मैडम.
Good evening
Good
everyone.
evening.
How is all of you?
Yeah.
All good?
या
Yes, madam.
Hello.
Thanks for
Yeah.
joining and sparing your valuable time.
Not
हेलो.
शोभा शुरू करें?
हाँ करेंगे. पद्मजा के पास तो लिंक गया
Four-
ही नहीं था.
4 PM
अभी
हो
मैंने
गया भाई.
भेजा.
4 PM हो गया.
हाँ पद्मजा के पास लिंक नहीं गया था, अभी मैंने भेजा है.
हम्म,
Let her join. She is the one who will start.
ओके
Give her a minute to join.
ओके.
Good evening, Dr. Duru ma'am. Good evening.
good evening. How are you?
Yeah. I'm good, ma'am. I'm good. It's wonderful to have you with us today.
Thank you.
Lovely
The
to have you with
Only
us.
thing is I don't know what I'm doing.
You have to
Tell
Bless
me.
us.
you
Give
have to
blessings.
encourage us for
Blessings.
this endeavor, and
Yes.
that's all. You are the mentor behind all this. No, this is actually slightly fluid for us also, because we conceptualized, but after this comes to pass only we will know how well we are able to do.
Actually, Neeta had done worked on this na, before on this.
हाँ हाँ, उन्हीं के इस पे ही तो जो भी काम उन्होंने किया है
हाँ,
उसी पे बेस्ड ही हम आगे जा रहे हैं. इनफैक्ट शी इज गोइंग टू स्पीक टुडे आल्सो ऑन फॉर्मुलेशंस.
हाँ.
I don't know why she has not yet joined. I think.
No, no, she is joined.
Ah,
She is
Meeta.
very much there.
Neeta will be there.
Hi, Meeta. Yeah, 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 yeah.
Hi.
Meeta.
Good
Yeah,
evening,
yeah.
Meeta.
Padmaja.
Padmaja has
Yes,
joined.
yes, yes.
Welcome Padmaja.
Yeah.
Please start. It is 4:02.
Yes, madam. I just got the link
Yeah,
because till
yeah,
now I was
please.
not having that. I will just
Please.
do that.
Yeah.
Hmm? Uh,
अभी भी गोरखपुर वालों को रिसीव नहीं हुआ है यूट्यूब लिंक.
अच्छा
Amrita has joined. Amrita
नहीं,
Amrita
अमृता के
has
पास तो
joined.
वैसा वाला लिंक है ना, देयर टू
उसने
लिंक।
रजिस्टर पहले कर लिया था.
हाँ, जो लोगों को बाद में हम लोगों ने सबने बोला कि हम लोग नहीं हो पा रहे हैं, देन वी हैव थॉट ऑफ मेकिंग अ यूट्यूब लिंक, एंड दैट कैन ओनली बी मेड जब ये खुला होगा ना 3:45 के अराउंड।
Good evening. Recalling that Sydney trip.
Uh, Shall we start, madam?
यस
You
यस
can see the screen?
Yeah, we can see.
Yes. I welcome all the dignitaries and all the faculty and all the delegates for this wonderful Indian Menopausal Society's e-prescription workshop, which is the module 1. And for this, we have this is being done under the aegis of the President, Dr. Anita Shah, and the course directors, Dr. Ragni Agarwal and Shobha, and all of us are working together for this. We'll have the modules happening on this module. We are a little late, but all the others are on first Wednesday of every month till 3rd December. And I welcome Dr. Anita Shah, who's our IMS president, who was the president of Surat Obigaini Society, and she's done. You can see the number of organizations Madam has worked with, and she's been in medical consultants for. She's worked with the IMS. She's worked with the
Padmaja,
IMA.
no need.
And so without much ado, I ask Dr. Anita Shah Madam to start the proceedings by welcoming our dignitaries, Dr. Rama Vaidya Madam and Dr. Durusha, and then her talk. Welcome, Madam.
Yes.
Uh,
Very good evening to all of you. Respected Rama Vaidya Madam and respected Duru Madam, who are our special invitees for today, as today we are having the first opening. You are opening batsman for our today's webinar, I can say. And thanks Padmaja for a nice word. Belated Happy Mother's Day to all of you again, and salute to our soldiers who just saved all of us. You all will agree with me that as the lifespan has increased, 1/3 of the life of a woman usually passes in the postmenopausal age group. We all are knowing each and everything of menopausal issues and menopausal problems and their solutions. But so many times we see that we are a little bit hesitant to write prescription for giving treatment to our menopausal hormone therapy to our patients. So Dr. Ragini and Dr. Shobha just thought that let us start this e-workshop for prescription writing. And I'm very much thankful to Ragini, Shobha, Dr. Lakshmi, Dr. Reena, Dr. Padmaja, Dr. Revati Madam. All of you have done a good efforts, and I'm sure that everyone will enjoy this. So without wasting any time, let us start our today's program.
So for this, we have messages from Dr. Rama Vaidya and Dr. Durusha. Dr. Rama Vaidya Madam is just Madam. Dr. Rama Vaidya is there, Madam.
Madam has joined.
Yeah, Madam is there.
I
Madam,
joined, and you can skip my introduction, please.
Just
I'm
a moment,
already.
Madam. Madam is the founder president of IMS 95 and 2000.
Yeah.
Madam is a reproductive endocrinologist, and she makes us look at every aspect, problem from just not the clinical aspect, but from the basics. So we really enjoy your insights, Madam, and a few words today.
Yeah. Thank you so much. And are we presenting my PPTs, or we are skipping it? If we are skipping
yes,
it, is
yes.
also.
Madam presenting.
No, Madam,
Paresh
you can
will do,
share.
Madam.
Madam, you can share.
No, I would not be able to,
No, Paresh
because I'm
will
not with
do,
my.
Madam. Paresh will.
Yeah. So I would have just said this way that being India's pluralistic healthcare we are compelled to understand trans-system prescription writing practices. Since I thought it was only on prescription writing, I took this opportunity, I'll say, I will not say trouble, it was an opportunity for me too. And so prescription writing in Ayurveda. And I was just thinking that probably we all know though, that Ayurveda's origin is from Rig Veda, but nowadays people are saying that it's the fifth Veda itself. And there are two classics, Brihatrayi, that is the major one, Charak Samhita, Shushruta Samhita, and Ashtanga Hriday. And Lagutrayi, that is the smaller one, is the Madhav Nidan, Sarangdar Sanhita, and Bhav Prakash. And they have ethical prescription writing as described in both major and the minor classics, Ayurvedic classics. Uh, Chikitsa Chatuspad, somebody's, I'm going fast because I'm giving it about 3 to 4 minutes. Are you,
Yes,
or
madam,
I'm
the
just
slides are moving, madam. We can see them.
That's great, great. So Vaidya should be a qualified and skilled physician. Dravya, that is medicaments. Nowadays, so much is prescription. Otherwise, people were used to make themselves. And there should be a nursing personnel or some attendant should be there and patient himself or herself. With the next slide shows that the after these 4 elements that we talked about, go to the next slide, please.
Yes, madam, it's there.
Yeah.
No,
The
previous one.
hallmark of Ayurvedic prescription, the 4-prong, that means that find out the causative factor or precipitating factor and rule it out, biopurification, then palliative remedies, and healthy lifestyle factors assessment and correction are always a part of Ayurvedic prescription. That's been written, and there are books written also. There are also articles which are systematic or also other kind of reviews are there, alternative reviews are there. Next slide, please.
Yes, madam. Drugs and prescription is being shown.
Yeah, yeah. So, 1 second, that I'm. It should be disease specific, palatable, minimal in dose and frequency, and proper something else. It could be milk, it could be water, and that is anupan. And dietary instructions, pathya and lifestyle is again a compulsory. And this morning only I got it from a friend of mine that how do you write an Ayurvedic prescription. I will not go into the details of this. These are there with you. And thank you very much for giving me this time. I thought that being a pluralistic system of medicine, we do come across uh, the prescriptions written by, and both at menopausal health, as we had said the other day, that they are for long-term on hormone replacement therapy, as well as they are also on long-term like Herde or Sudarshan Ghanvati, and these are common. So Ayurvedic pharmacoepidemiology work is going on in a large way, and then people are taking it for almost lifetime, also some of these drugs. Thank you very much for giving me this opportunity. Thank you.
Thank you, Dr. Rama Vaidya, madam. And now we'll have a few words of wisdom from Dr. Durusha, who's worked as a Foxy president, as ISAR president, as IMS president. She's put us in the landmark, and she's made people recognize that not only all the health problems, every disease, even like PCOS, has different ethnic variations, and we can't use the same size, one size fits all. Welcome, Dr. Durusha. Madam, you're muted. Yes.
Thank you so much for having me here today. I'm delighted to be here along with Dr. Rama Vaidya, whom I've always considered as my mentor. And I appreciate her and for her vision on so many years ago that she was able to think about menopausal health and menopausal women and create this multidisciplinary association, which is so very important for our country. Based on that, actually, I also thought of creating the PCOS Society of India, which is multidisciplinary, and it's moving great. And we see that a lot of PCO patients, after they reach menopause, they have a lot of issues which are related to, like it's double trouble for them after menopause. But thank you again, Anita, as president of IMS India, and She was the president of the Surat OBGYN Society when I was there as the president. And we had an annual conference there. And of course, I know she's a very, very hard worker and she'll do a great job this year. I'm sure she started off with a bang. And Ragini is there and Padmaja is there and all of you so well personally. I feel at home being here. A few words about what the world thinks about the Indian Menopause Society. I was the chair of the Council of Accredited Menopause Societies for 2 years at the International Menopause Society. After having been on their board for 8 years and being director of digital education, when I was the chair of CAMS, we created microsites of all the menopause societies in the world on the website of International Menopause Society. And you won't believe it, they picked up the Indian Menopause Society website as a great example of how the website should be. So I felt very proud at that time, and I must say that you all must utilize it well, because the microsite is on the international website. Whatever you're doing on your site can be seen by anyone globally. And that's how we have connected the entire world to the International Menopause Society. So that's one thing I think we have been bringing in, trying to bring all our societies up. And I must say that Indian Menopause Society is high up on the agenda there. The second thing we did was, of course, we created the IMPART program, which is a digital education on menopause, which is going all over the world. And now more than 3,000 people have done that course, which is available to you free of cost, I think, through Abbott. So if any of you want to do that course, it is a course which we developed almost 5 years ago. And this was through a grant which we got from an independent grants, which cost about almost $150,000. But it's a great program, and everyone can go through it and learn more about menopause. Because the constant complaint I get of people is that whom should we approach for menopausal health in the country? Because they don't know whom to approach when they approach gynecologists who are not trained in this field of prescription writing, which is so important today, that they say that it's not necessary to take hormone therapy. They give them all negative replies and are not willing to treat them with hormone therapy. So I think it's important for us to do this prescription writing, do the course on menopausal health, so that we are updated in whatever we are doing, so that we can be on par with everyone else in the world with treating. I know the Indian Menopause Society is very, very active, but we need to spread that education much more and get many more people involved in it so that we can treat menopausal women well. And I think this course is going to do a great job. With Meeta behind it, I know it will be wonderful. She has, I think, created this course, and I'm sure you must have updated it. And hats off to all of you. Go ahead and do it, and I wish you all the best.
Thank you, madam.
Thank you so much, Duru ma'am and Rama Vaidya ma'am. Thanks a lot.
My pleasure. Thank you.
So, Dr. Ragini, shall we start the academics?
Yeah, please.
Yeah. So the scientific program is starting with our President, Dr. Anita J. Shah, who's talking about physiological changes at menopause and need for menopausal hormone therapy. Dr. Anita, you can share the slides, please. Or do you want me to share? You tell me, anything is fine. Madam, if you want me to share, I will share it for you. Yes, yeah. If you can make it full screen, yeah, that's perfect, madam. You're muted, Dr. Anita.
अनीता जी अनम्यूट कर लो.
Yeah.
Yes, madam. Now we can hear and see you.
Right. Yeah. So, thank you, Ragini and Shobha, for giving me the opportunity to be the opening batsman. Usually, what I am going to talk, it is just to recapitulate, all of us know physiological changes at menopause and need for MHT. You all know that menopause is a universally experienced transition from a woman's reproductive years to non-reproductive years. Menopause is characterized by the permanent cessation of menstrual cycling and is clinically defined as the absence of menses for 12 months. We all are knowing the SWAN study, which was started in 1996, and it had enrolled 3,300 women, 3,302 women at 7 geographically distinct sites across the United States. Similarly, we all are knowing about the stroke classification also, which represents the reproductive menopausal transition age as well as post-menopause. It defines the early and late perimenopausal period where the duration of which is variable. The symptoms, there is mainly menstrual cycle, which is during the transition of menopause. It is variable. In early transition, there is a variable length of the periods and the more than 7 days difference in the length of the consecutive cycles, where interval may be in later age, there may be more than 60 days. So all this is known to all of you. Here we always remember our beloved past president, Dr. Behram Ankleshwariya, who had made the modified Ankleshwariya's classification, and it was taken in the consensus also. So I think no need of describing all of this, because you are all knowing when it is in patient is in stage 1 stage, we have to do preventive measures. Whenever in stage 2, then we have to treat the patients, offer various symptoms. This is the window of opportunity where we have to take the advantage and we have to counsel the patient and treat her in a proper way. While in stage 3, it is the palliative treatment is to be given. So if we look at the reproductive axis, patterns of E2 decline and FSH rise during the menopause transition are heterogeneous across women, irrespective of race or ethnicity. A midlife rise in E2 before the final menstrual period is most common in non-obese women, whereas obese midlife women are more likely to experience a non-rise E2 and a low-rise FSH over the menopause transition. This rise of E2 is responsible for most of the abnormal uterine bleeding patterns, endometrial polyps, hyperplasia, and growth of fibroids. So unless strongly indicated, hysterectomy should not be the first line of management, as menopause is the end of AUB. So we have to conserve the uterus. Always we have to convince our patient, because most of the patients will always say that I'm having this type of abnormal bleeding and you just take it out. Regarding menstrual cycle patterns, cycle length increases over the menopause transition, particularly in the upper tail of the distribution and in cycles without evidence of luteal activity. Almost a quarter of midlife women may experience an ovulatory cycle in the last year prior to their final menstrual period. So contraception is necessary to prevent unexpected pregnancies. Patient can conceive, we all know that patient can conceive even at the age of 43 and 44 also. So sometimes patients are also confused and they will not agree that she has conceived at these age. But we have to tell our patient and we have to advise the patient to prevent conception during this age also. You all know that early stage of menopause transition is characterized by a persistent 7+ days difference in consecutive cycles. Late stage of menopause transition by 60+ days of amenorrhea. Smokers experience earlier menopause transition onset, shorter menopause transition duration, and earlier age at natural menopause. Regarding vasomotor symptoms, which are the most common symptoms, we can say, especially during the transition phase, Up to 80% of midlife women experience vasomotor symptoms during the menopause transition, with a pattern of vasomotor symptoms heterogeneous across time. Vasomotor symptoms can last more than 8 years, with a longer duration of if experienced early in the transition. Adiposity could be a risk factor for vasomotor symptoms early in the transition, but appears to be protective in later stage of menopause transition. So transient nature of these symptoms in most women is reassuring. So diet, exercise, lifestyle modification, yoga can be the first line of treatment with lowest possible for the shortest duration of MHT when they don't get relief by this lifestyle modification. You all know that self-reported sleep complaints increase across the menopause transition. During midlife, sleep duration and deep sleep measured objectively do not worsen and may improve. Poor sleep may have an adverse impact on the women's cardiovascular health at midlife. Depressive symptoms and anxiety, they are also very common during this transition phase as well as in menopause and postmenopause. Depressive symptoms and anxiety are somewhat higher during the peri and postmenopause than premenopause. Testosterone is the only hormone related to depressive symptoms. Other factors such as stressful life events, financial strain, lower social support, sleep problems, and low physical activities are important contributors to depressive symptoms and or anxiety independent of the menopause transition. So encouraging physical activity, improve social networking and support groups, seeking professional help are the need for of an hour. Regarding cognitive performance, menopause-related cognitive performance difficulties are characterized by a temporary absence of learning during perimenopause that resolves in postmenopause when learning resumes. Solving puzzles, learning new skills is of the benefit. Age-related cognitive performance decline starts later after menopause and is related to the chronological age, but not to time since the final menstrual period. Genitourinary syndrome and sexual health, it is of utmost importance. Of course, at these age, most of the patients don't bother for that. Usually, they are very much hesitant to speak about that also. Decline in intercourse frequency does not lead to the vaginal dryness or pain with intercourse. Urinary incontinence is a frequently reported symptom among midlife women that is not related to menopause or estradiol decline. Sexual functioning declines become apparent 20 months before the final menstrual period and slows after the final menstrual period. Use of vaginal lubricants, topical estrogen goes a long way in preventing all these problems so that patient can enjoy her sexual relationships in a better way. Cardiovascular health. Women experience adverse changes in their lipids, body fat distribution, metabolic syndrome risk, and vascular health over the menopause transition. Increases in LDL-C around the final menstrual period are associated with greater risk of plaque presence after menopause, but higher levels of HDL-C may not consistently be the protective. Menopause transition-related fat redistribution extended to other critical locations that are relevant to cardiovascular health. Sex hormones and greater vasomotor symptoms appear to be related to adverse changes in cardiovascular health, with risk varying by patterns of E2 and vasomotor symptoms over the menopausal transition. So optimizing body weight, regular physical exercise, care of diet, annual lipid profile, control of comorbidities like hypertension and diabetes, physician checkup with use of statins and aspirin, they are definitely going to help. Use of MHT in early menopause before the established coronary artery disease decreases the morbidity and mortality, but the pros and cons need to be discussed and a proper decision making should be done. Bone health. It is also of utmost importance. Bone mineral density loss starts a few years before the final menstrual period. That is during the menopause transition, not after menopause. Osteoporosis being a silent killer, we all know. Active measures for diet, exercise, including weight-bearing exercise, vitamin D, go a long way in preventing fracture. if you look at the physical functioning, although physical functioning limitations are prevalent among midlife women, they are not necessarily a persistent problem. The menopause transition is associated with poor self-reported physical function that is related to decline in E2 and T levels over the menopause transition. Symptomatic changes experienced by menopausal women, including vasomotor symptoms, poor sleep, and perceived stress, may negatively affect physical functioning status. Physiologic changes across several body systems during the menopause transition may underlie the observed changes in the physical functioning during this time. So we have to take advantage of the window of opportunity where awareness should be properly spread, adapt the health behaviors in a better way, and design the early preventive practices that we have to counsel our patients and we have to treat our patient in that way. So in conclusion, I would like to say that menopause is a biological, symptomatic, and psychosocial changes. There is a diversity of experiences among women, especially those of different racial, ethnic backgrounds, and underscore the multifactorial nature of the menopause therapy as a landmark even in the women's life. In addition, the findings point to midlife as a critical stage for adapting healthy behavior and preventive strategies. So I think this is, in nutshell, the physiological changes. All of you are aware of that.
Thank you, madam, for setting the tone for the rest of the workshop. You've given us an overview of everything. And I don't see any questions in the chat box. So if any, Dr. Sudha Sharma, do you want to say anything?
We can continue, please. Question answer at the end, please.
Okay, madam. So for the next talk, we have Dr. Meeta. To understand, now we know that there is a need for menopausal hormone therapy. Dr. Meeta will take us to understanding the hormonal formulations, whether to do estrogen, whether to give estrogen progesterone, whether to do oral, whether to use non-oral, when and where. And for that, we have Dr. Meeta Singh to tell us about that. And madam is director consultant at Tanveer Hospital, Hyderabad. She's worked for more than 30 years in the field of menopause, postmenopausal osteoporosis, PCOS. And she is also a good endoscopic surgeon. She's got numerous awards, and she was the editor and chair of Journal of Midlife, and she was instrumental and played a big role in getting us these clinical practice guidelines on menopause and postmenopausal health. She was the past president of IMS and founder patron of the Hyderabad Menopause Society. And we're proud to have you with us, madam, and your books are like the Bible for us to read. Thank you. Dr. Meeta, please. Madam, that was perfect then. When you put it on the slideshow, it came out well.
Okay.
No, this one, it came out. Now it's correct.
Yeah. Hello. No, I thought I was in the mute, so I had to go back and then,
This is fine.
Yeah. So thank you so much, Padmaja. No, I think again there is something wrong here.
Okay, I think when you move the mouse, it's going away.
Oh, it's fine.
Yeah.
So thank you so much, Padmaja, for the very kind introduction. A very good evening to everybody. And first, I would like to address Dr. Amavaidya. Ma'am, thank you so much for being here. And so your, the 2 or 3 minute always speaks volume. Because very rightly said, I think for this prescription workshop, the message that you've given is the medication is just one small, minuscule part of the entire treatment program, be it Ayurveda or be it allopathy or any kind of treatment that a doctor is giving to the woman. So I think that's a very important message, that hormones are not an end of all to the management of menopause. And of course, Dr. Dhru's words of advice, and how she has, how the Indian Menopause Society is showcased at an international level. So I think Sunila and many of them deserve that credit. And I would congratulate and also give my best wishes to Anita, Ragini, Shobha, and Padmaja and the entire team who have worked on this modules. And this is the need of the hour, where the implementation is important. So whatever was there was in the books. Now it's a time that implementation of whatever is there has to happen. And a very special and a very warm hello to Sudha, after all those problems that they've been undergoing. So welcome to all of you and all my colleagues who have joined in today to listen to this particular module. So understanding hormonal formulations, maybe I may not, exactly give when and where and all that, because Shobha had told me to concentrate on the hormonal formulations as such. And then you're going to have so many of them talking about different aspects, the regimes and all of that. So I'm not going to go into that. I'm going to stick to the formulations in this 15 minutes, the physiology and the pharmacology. And most of the references are, taken from the initial prescription, what we had done, the first part of the 5 modules that we had done in the beginning. And but anybody who's interested in the basics of estrogen and progesterone, I would urge them to read full pharmacology of estrogen and progesterone. It is available on the Climacteric 2005. It's an excellent read to understand the basics of estrogen and progesterone. So now the content is physiological estrogen, pharmacological estrogen, and then available formulations in India. This is how the flow is going to be. All of us know that that the estrogens that are available in the body are of 4 types. That is estrone, estradiol, estriol, and estetriol. So it is very important to understand what is biological hormones and how they act at different levels to understand the pharmacology. So I thought I would start with this. And also we understand that the different types of estrogens are produced from different organs of the body in differing amount at different phases of a woman's life. So a woman's life at different phases may produce different, the ratio of these hormones keeps changing according to the need. Now, estrogens are produced mainly from the ovaries during the reproductive lives. During pregnancy, we know it's the placenta which is giving you so much of your estriol, which is maintaining, because everything is suppressed. The ovary is in a quiescent phase during your pregnancy. Then during menopause, what is happening? There is a reversal of the roles. And we know the ovary becomes like a male function because it's more of the testosterone, and from there you're getting all your estrogens. And the rest of the estrogens are coming from the adrenals, from the fat, and so many extra gonadal sites which will be adding on. And so that is why talking about estrogen is not easy. It's an elusive molecule, and each woman is different. Each woman's formations are different. So when you give the pharmacotherapy, the formulations, each woman may react differently. The microbiota in the intestines are also different. So absorption of the estrogens that you're giving in may change. So we have I'm not going to go into the basics, but yes, there are different ways the estrogen acts at the receptors. But this slide, which I have shown, to indicate that it is not just reproductive function estrogen is involved. And that is where the menopausal problems come in. Because if it's only estrogen, nothing would have happened when the estrogen has disappeared at menopause. Things would have been okay. But we know that the receptors are present all over the body, and that is how the estrogen deficiency causes the problems. But we have to also understand that the estrogen, everything has to be at a level. Anything in excess, anything in deficient is always bad. Similar with estrogen, and that's what these slides go to indicate, that when they're physiological and in excess. And I must congratulate Anita for the beautiful roundup of the physiology, put it in a very different way, starting off with the swan. And I really was, taken. I mean, it was so pleasant to watch that beautiful background that you have put up, that lovely flowers and the dried leaves. The background is also excellent, Anita. So, and as you have very rightly said, that during the menopause transition, you have the physiological excess and all the endometrial polyps, endometriosis, the fibroids, everything blows out of proportion at the menopause transition. So that's why we must remember that the potency of each of the estrogens which are available in the body depends on the nuclear retention time. So where it dictates what has to be done in each particular cell. So 17 beta estradiol is the most potent and has the longest retention period of 6 to 24 hours. Estriol, very, very less, hardly about 1 or 2 hours. Estradiol is 10 times more potent than estrone and 80 times more potent than estriol. And these are the basics which you need to remember when you're prescribing the therapy. And that is why we used to have Evalon tablets, but we have never used them for vasomotor symptoms. We are using them only for the GSM because they wouldn't work as well because the potency is very, very little. So we're coming to the pharmacology. There has been a change in the terminology. So earlier on, we used to call it hormone therapy. Now we call it menopause hormone therapy. And there's a difference in it. When you say hormone therapy, it is hormone replacement therapy. And we still use the term in premature ovarian insufficiency, or ET is estrogen, EPT is estrogen, progesterone, androgen. We don't have androgen therapy for use in women at menopause as of now. In between, there was a testosterone gel, which the infertility people were using, and some people were using it for menopause, but it was off-label. Now, the estrogen combinations which are available to us is only Timolone. We don't have the bezidoxifene in India. So there are different types of hormone therapy which are available. It can be in the tablets. Of course, we don't have the capsules. We have the tablets. The skin patches came and went because they didn't do well in India. We have the gels. We have the vaginal tablets. Also, we have the transdermal spray. So when you're talking about transdermal, we have these two formulations which are available to us in India. So when you're talking about pharmacology, what are the natural estrogens, which are bioidentical? So we must remember, when we are talking of bioidentical hormones, you have to also remember to differentiate it between the compounded hormones, which are, being talked about a lot in the West and not in India. Luckily, they have not percolated in India, and hope they don't, because we have so many other things to deal with and we don't want to deal with the compounded hormones, because these are companies which just come out with these compounded hormones and they say they tailor it to the woman's need, but they are not tailored according to the FDA. So the quantity of the medicine that is there is not gone through the rigor of any trial. So it is better not to prescribe the compounded hormones, if at all, when they come to India. And hopefully they don't, because the West is still struggling with them. So bioidentical are biosimilars. That means they are same as the native estrogens which are there in the body. And that is what we call the MHT. That is 17 beta estradiol, estradiol valerate, estriol, estetrol. So estetrol is doing the rounds in the West. It's already available for contraception. And they are also working very hard to see to it that it's also included in the menopause hormone therapy. So the next 10 years, we may hear more about the estetrol. We have the conjugated equine estrogen. The synthetic estrogens are the ethinyl estradiol. I remember about 20 years ago, people used to prescribe ethinyl estradiol because it was much cheaper than the 17 beta estradiol. But now we know that this is not to be prescribed at menopause, because again, you're going to do more harm than good. And that is very, very important. This is one of the most important slides of my presentation today, because if you understand this slide, it is easy to understand the formulations. So I'm not going to go into the details because it's all very, very clear. I have, put the round marks on ethinyl estradiol. So you see, when you're looking at the hot flush and the effect of ethinyl estradiol, 5 micrograms of ethinyl estradiol is equivalent to 0.5 milligrams or 1 milligram of the estradiol. So you see the difference in the amount of estrogen therapy that you would need when you compare the estradiol to ethinyl estradiol, the conjugated equine estrogen, and the transdermal also is much micrograms. So the amount that you need, the estradiol, when you're giving a transdermal therapy, is much, much lesser than what you would be giving for your hot flush by an oral therapy. Now, what is the difference between the 3 commonly used therapies that we have? So commonly used formulations that we have in India and that we are prescribing are the 17 beta estradiol hemihydrate. That is the 17 beta estradiol, which is commonly used in most of the combination pills that we have today. We also have the estradiol valerate, which is a huge favorite of all the infertility specialists. They use that very, very commonly. And there are a couple of studies of estradiol valerate even in use in menopause hormone therapy. But I think it didn't really pick off as much as estradiol because it needs to be converted in the liver to 17-beta estradiol and a valeric acid. So that means the dose of estradiol valerate that you need when you compare to estrogen estradiol would be more. So it has to go through the first bypass metabolism. So the liver has to act a little more than what it has to do when you're giving the 17-beta estradiol. Similarly, conjugated equine estrogen is a very special separate molecule altogether because it is a combination of different estrogens put together, extracted from the urine of pregnant mares. And it's still a favorite of mine because it does in severe cases of hot flushes. The one which really works is conjugated equine estrogen. The results are quicker than 17-beta estradiol. It is more potent. But the problem is this, yes, the liver has to work again a little harder to break it into different metabolites. So, and the prothrombotic effect of some of the metabolites may lead to an increased risk of VT. So just like your antihistaminics, you want the antihistaminics to work very well. The side effect, the dizziness and the side effects are more. So it's similar to that. You want the best and you also have to deal with the other side effects. So that is the difference between the three formulations that we have. When you compare the 17-beta estradiol to ethinyl estradiol is an absolute no-no at menopause. It can be reserved to the younger women who have no other problems where the age is different, the baseline risk for the cardiovascular is very, very different because it is a synthetic molecule. And of course, it acts on the receptors and it is commonly used in the COC. Even in the COC, from 50 micrograms, now it has come down. The lowest dose that we have is the 15 micrograms. But for use in menopause, it has to come down to 5 micrograms. But in the younger age group, that would cause a lot of your intermenstrual bleeding. So it is not at all accepted. 15 is probably the lowest that can come to in COC. So it is extremely extensively conjugated. But remember, unlike 17-beta estradiol, the estradiol, ethinyl estradiol, whether you give it orally, or whether you give it transdermally, or whether you give it vaginally, the effects are the same. So there is no difference in the effect of the ethinyl estradiol. That's how the Newell was there in the market, if you remember. I mean, we were using it quite a lot for women with that ring. Very simple. Once a month, you change the ring. And that is how the ethinyl estradiol was. So except in premature ovarian insufficiency, you're not going to use the ethinyl estradiol for women at menopause. Now, progesterone, the role of progesterone in hormone therapy is it reduces the risk of endometrial hyperplasia. And of course, the endometrial cancer if you're giving only unopposed estrogen therapy. But there are so many different types of progesterones. We know in the body, there's only one natural progesterone. But the formulations that are there are so many, and all the gynecologists are very well versed with the different formulations that we have today because we're using all these progesterones for very different reasons. But I have just picked up the ones which we are using in hormone therapy. The commonly used one is the dydrogesterone and the progesterone today. The medroxyprogesterone, as you know, in the menopause world, people say the medroxyprogesterone after the WHI from a hero, it has become a zero simply because of its effect on the lipids, simply because of its effect on the breast. So now we see that we are no longer using medroxyprogesterone, but there is a role of medroxyprogesterone when you're talking about cycle control in the perimenopausal time when you need a more effective progestational activity on the endometrium. And that is where the medroxyprogesterone and norethistron also plays a role because these two are very, very effective, just like levonorgestrone. The advantage of levonorgestrone over medroxy and norethistron in menopause hormone therapy is, one is it is an IUD. I mean, you insert it inside the, it's a system which you put it inside, and it does not have an effect on the VT nor on the lipid profile, unlike the medroxy and norethistron. Now, there people are again showing some association of LNG with the breast cancer, but it is very, very minute and we should not be deterred by it. We can give it very, very safely because the advantages are much more. So when you come to hormone therapy, the best bets are the dydrogesterone and the progesterone. So I've given you the good, the problem, and the availability. So this is also a very important slide to understand all the progesterones in a nutshell. So the routes of administration, we know we have oral, transdermal, and vaginal. And for progesterone, we have the intrauterine system that we have. So on the right side, I have just put in, how the oral route increases the triglycerides, increases the C-reactive protein, the clotting factors, the sex hormone binding globulin. So when it increases the sex hormone binding globulin, it also mops up the testosterone. So the levels of testosterone comes down. So this is one reason why we are not going to give MHT when there is a low libido. Then you would prefer a transdermal than an oral therapy. So routes of administration are important. So where are we giving the transdermal? In cases where there is increased triglyceridemia, because otherwise, if you give oral, it may precipitate acute pancreatitis, active gallbladder disease and polylithiasis, migraine with aura, because the chances of, again, VT are very, very high. Obesity is, again, thrombogenic, age more than 65, thrombogenic. So any thrombogenic potential, go for transdermal. Low libido, go for transdermal. Oral is preferable whenever there is a low HDL, high LDL, high lipoprotein A. Oral MHT works wonders. So these are the situations where you go for oral rather than the transdermal. So transdermal is not an answer for everything. So there are 3 types of estrogen therapies that we are starting. The types of therapies that are available to us in India is the conjugated equine estrogen. We have the 0.3 milligrams, we have the 0.625. We have the 17 beta estradiol, which is 1 milligram, 2 milligram. We have the transdermal gel and the spray, which contains the 17 beta estradiol, 25 to 100 micrograms. So this is there in the form of gel. And when you're talking of spray, each accutation will give you some 0.53 micrograms of the 17 beta estradiol. And we have the oral valerate as 1 and 2 milligrams as well. So these are the estrogens which are available to us in India, these formulations. Progesterones, again, micronized, we have 100, 200, 300, 400. And we have the dydrogesterone only as a 10 milligram. We have the device which releases 20 micrograms. Medroxy, all of us know we have the 5 and 10 again, but we are not going to use it. So when you come to the combination therapies which are available, luckily, we also have the combination therapies. Earlier on, we would have to match the combination therapies. We have the 1 milligram 17 beta estradiol and 10 milligram of dydrogesterone available as Femestone 1 by 10. We have Femestone 2 by 10. We also have Femestone Conti, where there is a for continuous combined regime, where we have 1 milligram, 5 milligram, and we also have the Femestone Mini, which has 0.5 milligram of 17 beta estradiol and 2.5 milligram of the dydrogesterone. Apart from that, a very interesting molecule that you have, there's a typing mistake over here. The MEMUP has 17 beta estradiol and 100 milligrams of plain progesterone, not dydrogesterone. So there is typed it wrong. 17 beta estradiol and dinogestrol is available as a Clyra, especially in the perimenopausal period. It also works for because we have a natural estrogen can be used. Then Tibolone is the only drug which has estrogenic, progesterogenic, and androgenic activity. So whenever you need that extra, feel good or androgenic effect, then Tibolone is available, which can be given. And vaginal estrogens, we only have 2 types available with us. That is the estriol succinate, the Evolon cream, 0.5 milligram. That's it. Oral tablets are not available as of now. And I hope they come back, because some of the old people would rather prefer the tablet than the vaginal cream. They are, struggling to get it back. Then we also have the Premarin cream, which is 0.625 milligram vaginal. So when you look at Tibolone versus 17 beta estradiol and digesterone combination, so this also is a snapshot view. Generally, both of them work well, but you know that cardiovascular, the combined biosimilar is more friendly to the heart, and also the effect on the breast, both of them, they don't have. But there definitely has been a slight weight increase with Tibolone because of the androgenic effect. And here there is no change. Abdominal discomfort, and I think the pricing is almost the same. And the flushes, I think both of them are equally effective. The VMS, they have said that this is almost up to 90%, and maybe this is up to 80%, not really too much of a difference. So at this particular point of time, I end with this beautiful painting by an Iraqi artist taken in an orphanage. The little girl has never seen a mother. So she drew a mom on the ground and fell asleep with her. So I end saying that appreciate with what you have, since you don't know what you have got unless it's taken away from you. And that too when it's too late. So I think hormone therapy is just, again, one part of the entire menopause management. So there's much, much more to it. Thank you very much for giving me the opportunity, Shobha.
Yeah, thank you, Meeta. Thanks a lot. My God, that was such an eye opener. I would prefer that others will give their comments because we are anyway talking in this. So yeah. Any
Smita, I have got a
questions?
question.
Yeah. Yeah.
See, one question. In POI, you said that ethanol estradiol is preferable. But what do you think? Is it the 17 beta estradiol is better than this because the dosage is little higher, isn't it? Comparatively, 17 beta only is preferable. No. Yeah.
Revati, now
Yeah.
earlier we were earlier on we used to say, hello Revati, I see you're
Yeah.
traveling.
Yeah.
What earlier we used to say that it's okay if you can go ahead and give the the COCs, that is the ethinyl estradiol, because young women are more comfortable. But now definitely we have got a lot of data to say that ethinyl estradiol scores over the 17 beta estradiol combination score over ethinyl estradiol is good evidence now, which we didn't have
Yes.
earlier. Entire health of, but except because this is available for us as an essential drug in the government hospital. So you see only in those women where the hormone therapy is not as an essential drug as of now in the government sector, whereas the COCs are. So the young, the less than 40, we have so many women who are castrated less than 40, almost 17% in Telangana. So these women would be benefited by the combination from the government sector. That's, I think, for India, probably we have to think differently.
But as I said, the dosage is only in micrograms, whereas this is in milligrams. Quite a good
5 micrograms
amount.
is already ideal, but then we don't have a 5 microgram formulation, isn't it? Most of them is 20, 25 or 30. The one which is available for in the government sector is also, I think, about 20, 25, 30. I don't remember.
No, 30 only is available. Government does not give 20. Does not give 20. Only 30 is
Does not
available
give
in the
30.
form of a COC. Yeah, in the form of a COC.
Yeah.
Yeah.
Where
So
5
it is not.
micrograms is 50 micrograms.
Yeah.
You
Not
can't
a
give a 30
suitable thing.
micrograms to a menopausal woman, no? You would end up with more problems.
Yes.
So, can I say something,
Yes,
Shobha?
ma'am.
Of course.
Yes,
Of
Shobha.
course.
Okay.
Of course.
So first of all, thank you, Dr. Mita, for your, those lovely wishes. And I tell you, it was so much required at that point of time. And a wonderful presentation. I tell you, it was a revision of what we knew. But, you have made it so clear what is available in India, what is not available in India, what is to be given and what is not to be given, what is the best and what is, upcoming. My, question again is, we had this one CME in physical CMA in Jammu only, and there was a debate. POI, should we be giving OC pills till what time? I was in favor of giving HRT, but what are the patients where we need to give them, OC pills over HRT? For how long OC pills? And then when to shift to HRT?
Yeah, thank you, Sudha. So now for this question, no, we don't have too much of evidence, but from sensibility, and for the little literature that we have, because now the evidence is collecting over the POI with the use of the natural hormones. But we could say, because at the younger age group, the amount of estrogen that would be needed is higher. Say at the age of 25 or Turner syndrome, and these people may need more of 17 beta estrogen. So instead of giving 3 tablets a day, that would amount to 15 micrograms of ethinyl estradiol when you compare. Say, if you're giving 2 mg of 17 beta estradiol, that will become 6 milligrams. So it's better to give a 30 milligram, 30 micrograms of ethinyl estradiol. It doesn't matter at that age. But as they are coming to 40 and 40 plus, you have to anyway reduce the dose. So as you're reducing the dose closer to menopause, or if they develop any cardiovascular, so you check them annually. And if you have any cardiovascular problems at that time, then you're going to reduce the dose or shift to the transdermal. So it's very individual. That's why I said the potency is very important. And
I agree.
Yeah.
I agree. Just a moment. Padmaja, just give me few seconds. That's all. I won't take more time. I know time is of critical essence in this. Just wanted to add to that we will discuss this a little bit further when we do the prescription part. We will do. And I just interjected for only one thing. I am requesting Meeta, Sudha, and all other seniors to please stay till the end if possible. Because, when the final prescription is written, we want all their opinions. That is why. Thank you so much. Yeah.
Um,
Just one question. Can I ask one question to Meeta?
Yeah, of course.
Yeah. Meeta, what about the refill over the counter when things are available? How do you prevent that? And so, is there any kind of a for a refill?
Not that I know of,
Meeta?
ma'am. That is, yes, hello, ma'am. That's an excellent question, but it's all beyond our NGOs and the clinicians. It's all in the hands of the government machinery, where the rules have to be very strict, except for very few medications. Most of them are available over the counter. So it's a very difficult situation. That's
Okay.
why
Yeah.
people go and buy the Evalon cream. Once they get better, they keep taking the therapy for a long time. So now sometimes I wonder, like you used to say long back, ma'am, that overuse and unintended use of hormone therapy should not be there.
Yeah. Okay, so we may give suggestions. We cannot produce guidelines because now it's against ICMR. They say that you can't produce guidelines from associations or society, but we can give suggestions. So when you are writing, maybe we could do that.
And
Yes, ma'am. Thank you.
Dr. Meeta, request, could you answer the questions in the chat box? I don't know whether we will have time later. So in the chat box itself, if you look at the questions and answer, it will be great. And
Can you read out, so we can save time, no? I mean, by the time I look up.
that's what, madam. They're there, you can see. So the next talk that we are having is on patient assessment and monitoring. What we need to do by the time we, how we go about making sure the checklist is there. And for this, we have Dr. Ragini Agarwal, who's the famous cosmetic gynecologist, the Secretary General of IMS. You can see her CV. She's been in the IMA, she's been in the OB-GYN, she has numerous awards and almost all commitments and social, and I wonder how madam keeps up with everything. So you can have a glance at her CV, and welcome Dr. Ragini.
Thank you so much, Padmaja. I think I just share my...
Yeah. Yes, madam, we can see it should... Yeah, this is perfect.
So thank you so much, everyone who has joined. My sincere gratitude to Rama Vaidya madam and the Durusha madam, and no doubt Meeta ji, who has spared their time and giving us a direction. And this is one topic as I grew older in the medical field, and I found my niche my calling is in the menopause, because this thing is neglected totally. And I think with the longevity, we are all going more of the patient of the menopause in our OPD than the antenatal patients. And this is the high time when we start looking for an antenatal card, a menopause card, and which is very, very close to my heart. Let's see when I am able to bring you all that menopause card. Although long back, in our Bible written by Meeta ji, it is there. So patient assessment and the monitoring in menopause women focuses on evaluating their health status, identifying potential problems, and managing menopause-related symptoms. The goal is to provide personalized care that addresses individual needs and the concern. So in that way, it is very different. We can't make a simple iron, calcium, folic acid to give all the menopausal women in a go, while also monitoring for the long-term health risk associated with menopause. So whenever we are going to evaluate a patient, these are the components which we should remember as a comprehensive approach: detailed medical history, physical examination, and potentially laboratory test and the imaging. So we think of the medical history. First, we have to listen the patient. There must be some direct question like why she is visiting clinic, is she having any complaint, she has just come to discuss preventive care, or to judge her awareness regarding menopause and we have to document it in the card also. Then a detailed menstrual history, when she has attained menopause and when she has started Minaki. That is also very important to know. Years post menopause, type of menopause, premature, early, natural, surgical. If surgical, whether it is only uterus has removed or ovectomy has also been done, changes in the menstrual cycle before attaining menopause, any pain, any heavy bleeding, decreased cycle, increased cycle, any issues during transition. Some directed question like changes in her mood, especially. Ever taken any treatment for any symptoms during this transition? And obstetrical history also play a very big role. As we know today, the person who is having a GDM or PIS during the antenatal period, those women are going to have more problem in the menopause. Maybe they are going to develop the diabetes, they are going to develop the metabolic syndrome, and those are the patients who are going to have more of the vasomotor and the cardiac issues also. Then history of the anticoagulant during pregnancy is shown that might be she is a candidate who has a more tendency to the thrombotic. Before giving any MST, we have to think about the VT and the thromboembolic phenomena. Then contraception history. Medical history, any known comorbidity, duration, treatment, personal history of use of tobacco, alcohol, and the recreation drug. Family history in the form of diabetes, BP, thyroid, cancer, specifically the type of cancer and the relation to the patient and of the which degree. Then don't forget the use of the sexual history, because today the woman is changing. They are getting in the new relationships, in the marriage, even they are getting married after during the perimenopause. So, and new community has appeared, those heterosexual and LGBTQ community. So that is also very important, how to give this transgender, what type of the MST to be given to them. So active or not active for the sexual activity. If activity, what is the frequency, use of condom, any issues in the intimacy should be discussed. We can use some questionnaire and few directed question about libido, dyspareunia, vaginal discomfort should be included. Then immunization history, that is also very important. Psychological evaluation is a very important thing, and it plays a very big role in the menopausal transition. A woman who has a past history of depression have more problems, and they can go in a big depressive attacks during the menopausal era. Even due to the hormonal fluctuation, retirement, emptiness syndrome, loss of a spouse, apathy of a spouse, financial crunch, all of these things, caregiver to the elderly. So directed question for above mentioned problem should be asked. If necessary, referral to a trained clinical psychologist is warranted. Now coming to the physical examination, although we have to do a detailed general and the systemic examination, which we all know, but what we have to focus, breast and the external genital examination, which is very, very necessary, clinical breast examination, and this is a time to teach her to do by herself monthly. Clinicians play a major role in the recognize the sign of GSM because many women are reluctant to report their symptoms. Examination of vulva in detail is very necessary. Maybe the sign of atrophy, any lesion, maybe the starting of a LSA is there. Then the examination of vagina. We have to take some tools, use of tools to document examination at the time of booking and the further changes or response to treatment. Few tools for the vaginal examination like vaginal maturation index, or a very simple, very, very simple, which we can easily do is a vaginal health index syndrome in these cases. And if there's a component is scored on a scale of 1 to 5 and lower score indicate more severe atrophy. Then laboratory test, there are certain tests which we do annually, which we do 5 yearly, and we have to educate those patients for that also. So specifically FSH, we usually not ask this patient to do, but a patient who is on the younger woman coming with the irregularities or a perimenopausal symptom to rule out the POI, or women on the LNG IUCD who are already have a amenorrhea for so many years, whether they have transit through the menopause or not. So hormone tests like FSH can be done. All regular tests we have to done, but the pap smear, LBC with HPV up to the 65 years, every 5 years is really necessary. Breast ultrasound and mammography, ultrasound less than the 40 years, and after 40 years, ultrasound and the mammography. Whole abdomen ultrasound with TVS is really, really necessary, specifically as ovarian cancer does not have any screening test, and many times the only flatulence and gas and this and that, the abdominal symptoms can be a early sign of the ovarian carcinoma. Central dual X-ray absorptiometry is also necessary, and the additional test can be added in the special circumstances with type of comorbidities. Menopausal symptom evaluation is done, assess the severity and the impact of the various symptoms. Certain score and assessment tools should be used for the risk stratification, and menstrual irregularity, including menorrhagia, can even last for years. Such a period is called perimenopause. So this is a scoring system which we can use as this Australian Menopause Society has in. We are using this particular score, and it's a very simple and very easy score and a very good score to follow up the patient when we put on the treatment or the holistic approach or the MST. So quality of life is very important, and we have to do the risk assessment, evaluate the patient overall well-being and how menopause affect their daily activity, assess cardiovascular, osteoporosis and other age-related risk factor to guide the preventive strategies. So we all know that for osteoporosis, we can have this chart OSTA in our chambers, cardiac assessment tool we can use, and we can use this RKF questionnaire for the assessment of the sarcopenia, which is really a good big problem in the menopausal woman. So lifestyle assessment, what she's taking, what exercise she's doing, what type of stress she's having, and the sad that is smoking, alcohol, and the drugs. So we have to monitor those patients for the complication, maybe because of the hormonal therapy or other intervention, and address any concerns or the side effects promptly. Key consideration, if I say it is an individualized approach, long-term health, patient education, and the regular follow-up is the key consideration for this particular evaluation and the monitoring. To conclude, by implementing a comprehensive assessment and monitoring plan, healthcare providers can help menopausal women navigate this life transition effectively, manage their symptoms, and maintain their overall health and well-being. Thank you so much for patient hearing.
Thank you, Dr. Ragini, for that wonderful presentation. So you've reiterated what we say in clinical practice. Listen to the patient, do a complete evaluation, look at how much what are the contraindications before we do, because writing a prescription does not mean writing just a medicine. So it is evaluating and moving ahead. So shall we go ahead with the next talk, madam?
As a matter of fact, not only before prescribing, any woman who comes in the menopause transition or menopause, right? All these things we have to do just like a general family physician. We have to take care of them.
Yes,
So very nicely she has put it. Thank you.
Padmaja, go ahead. We don't have time actually.
Yeah. So we are moving ahead to coming to the prescription writing components, which Dr. Shobha Gudi madam will tell us about the prescription writing. And madam is HOD at St. Philomena's Hospital, Bangalore. She has been an active member of FOXY, Bangalore Society of OB-GYN, ICOG. She was peer reviewer of Joji. She was the chairperson of conception and reproductive health at all organizations, including FOXY, ISOPAB, and she has numerous publications and awards. Madam.
Thank you, Padmaja. Thanks a lot. Thanks a lot. Thank you.
Thank you.
So, so I can see that there are some questions in the chat box to Dr. Meeta. So probably I'm not yet seeing Dr. Meeta's responses. Yeah.
No,
yeah, thank you, Meeta. Thanks a lot. Yeah. So at the outset, let me thank the IMS office bearers, Dr. Anita Shah and Dr. Ragini Agrawal for encouraging me. And then, this is just the first one. So I feel that today will be a test or a trial of how well we do. So far it has been excellent. I thank Dr. Meeta's, Dr. Ragini, Dr. Anita's talk initially. Thank Dr. Padmaja for helping with the modules. and for comparing, and also Reena, who used to speak after me. Thank you, everyone, and my namaskar to Duru ma'am, and of course to Rama Vaidya ma'am. And I must say that, what I am attempting to do now, I will need a lot of help from everybody. So let us base some of our thoughts at least on the white paper manual, which was released last year. And then in that, we kind of crystallized the questions regarding MHT into who is MHT for, what types and doses of MHT. So these two have already been dealt with the past two speakers. When should MHT be started and stopped? And before that, what should be the evaluation? That is the one question which is not asked but has been answered by Ragini. Why is it important? Of course, that also partly has been answered, and where it can be accessed. So this is something which every gynecologist has to answer. This fifth question, where it can be accessed, it can be accessed by the patient when they come to us. It can be accessed across the table, and we must be sure to provide it. So once we have joined this, this Association of Gynecologists who are in IMS, we join the organizational body, we become a member, we do the CIMP exam, and we become, accredited to prescribe, credentialed to prescribe this. We must understand that globally there is a critical unmet need for easy access to evidence-based information, safe and effective management options for those needing treatment in this field. So very rightly said by everybody that Dr. Meeta and all the predecessors of who have worked in this field, they have been able to group the women into these group 1, where women are without any symptoms. So today we will not deal with it, because today we have a woman who has symptoms. So we go to the group 2, because this is about a workshop. We are not going to do the theory part of who all are there, who are the cohorts of women. We have to deal with this cohort. This is a woman with menopausal symptoms. Now, is she healthy with no problems? When I present the case, you will understand that she is actually healthy with risk factors for disease may not be that much, but she has symptoms of menopause. And we need to institute the preventive health care, and we need to give her she may not be a woman with latent disease, okay, but she does not have comorbidities as of now. So as I present the case, you will know that this woman belongs to group 2, and she is healthy and she's symptomatic, but she is healthy, and risk factors of disease may be there though. Let us see the case and then understand it better. She is a 52-year-old college lecturer, and she comes to you and she tells you that all is done, and 1 year 3 months back the nuisance stopped, but then she thought that she's well rid of it, but then she started getting these hot flashes and disturbance of sleep. And of course, she is not hysterectomized. The only thing which emerges from the entire history is that she mother died at the age of 70 years, at 74 years, and at 70 years, she was diagnosed with breast cancer. So now her BMI is 23. She's not obese, that means. And personally, also, there is no other significant history. So I would take this woman as group 2 who has symptoms, does not have any specific comorbidities as of now, because she is not a diabetic or a hypertensive. We have evaluated her and she does not come across. So then these are the questions. What type and doses of MHT? Okay, and factors which determine the type and dose, and this is in part we have understood with Dr. Meeta's presentation. We need to focus on her preference. The uterus is present here. Now, she does not have any contraceptive needs, though I did not describe her parity. She's a Paris woman with tubectomy done in the past. She is having symptoms which are, I would say, a little severe, because they're disturbing her sleep. And as of now, she does not have any comorbidities. So how to write a prescription for her? So let me begin by saying that let me give her a continuous option. So because I don't want her to have periods, so let me give this option to her, the 1 milligram, and I will now kind of make it into my slide is still seen. but now the difference is that I can make a change here. So my preference is the 1 milligram estradiol with 5 milligram dydrogesterone, and I want to give her a continuous combined regime daily at night. And then she gets concerned with the cost, and then I tell her that, okay, you can also have this kind of treatment where you combine the 0.3 milligram of conjugated or 0.625 milligram of conjugated equine plus which is not available in a combination, but then you will have to combine it with the progesterone. I would prefer that you kind of take it continuously, it is better, or 200 milligram of micronized progesterone. Now, here, when they are not available and in a common prescription, we may be able to tell them to take it from the 16th day to the onwards for at least, or 15th day onwards for at least 14 days. So then again go back to the single regime, to taking the conjugated equine estrogen. So these are my thoughts. Now, am I oversimplifying? Is the estrogen type important here? Is the progesterone type important here? This is the question that we will discuss, and then I will quickly go ahead with the rest of the presentation. So I will stop sharing here and I'll bring in thoughts, okay, and then we will go back, because otherwise the session will not be interactive. So anybody can tell me what are their thoughts here. Sudha, कुछ बोलना था आपको, Sudha and Revati madam and Meeta, if you are there. So we shall start this medication for this lady, and we will continue it for a period of, maybe she's just 52 years now. So we can continue it for some months at least and have a call back. Can I have your inputs? Sudha ji, आप क्या कहना चाहेंगे?
Madam, you're muted. Sudha madam, you need to unmute.
We can definitely give for the
I think
symptoms.
continuous combined, the
Yes.
lowest dose which you have given, the first
Yes.
option, I
Correct.
think that would be better
Yeah.
with, the best of the progesterone and in a continuous form. So that would be better,
Somebody
but
is.
yes,
There is some disturbance.
I think
Yeah, that, yeah.
Before it, we need to have, her mammography, since there is a family history,
Yes,
and
evaluation has been done. Yes,
very strict
evaluation.
follow up in her case.
Thank you so much. I'll put that in the prescription. Yes, anything else? Dr. Meeta?
Yeah, I think I would go with Sudha. That yeah, very important. I think here, no, the mammogram, of course, is an important thing, but in your history taking itself, the risk assessment that we do, like our OSTA, I encourage people to do the GALE.
Yes.
That just a confidence for the woman when you're makes them feel that you're really taking care. Because if you're doing the mammogram, that may not really add too much of value, but it still does.
The scoring tells them. Correct. The scoring tells them.
Counseling part, it just helps.
Thank you so
the
much.
choice dydrogesterone or progesterone, either way is okay. Yeah, Ragini has something to add.
Yeah, actually, a prescription should start from the counseling, not from the.
Yeah, I'll come to that. I'll come to that. I'll come to that. I'm sorry. I just wanted to bring in thoughts on the hormone replacement. That is why. So the counseling, why I did not put is the last talk is still to be done. After that, I will share the final prescription, which will include the counseling first. I thought we'll just finish the hormonal part and then we will go to the complete prescription.
Okay.
Otherwise, the discussion remains incomplete. Yeah, because then, this we can't keep this for the last. It becomes too heavy for the last. So I just wanted to know from the experts, or I myself want to say, am I oversimplifying? At this point of time, it looks okay. Is the estrogen type important? Well, estradiol is considered as a safe option in this age group, especially where the symptoms are saying that she is estrogen deficient. 1 milligram per day is fine for her. As all the experts have suggested, I will be counseling her for an annual mammogram and for a self-breast examination examination on a monthly basis, or at least in a 2 or 3 monthly basis. Is the type of progesterone important is also kind of a relevant question. And today we have dydrogesterone and micronized progesterone both. So here we go on to the next step. What if the woman is intolerant to oral medication? If she is intolerant to oral medication, especially to progesterone, then what has to be done? Sometimes they do not tolerate medication or to estrogen, whatever is, if it is to estrogen or progesterone also, I can tell, or to both I can tell. So now I wanted some perspective on whether we should, if they come back with intolerance, they're saying that, it is like for progesterone, they may have mood symptoms, they may have bloating, they may have some kind of heaviness, that is same as bloating, of course, irritability. So whether we should be thinking of any other, because she doesn't have any other comorbidities, she has an intact uterus. So should we have any other perspective on the progesterone or the estrogen? So is transdermal estrogen or any other type of progesterone to be done? Because we need to make sure that the hormones are delivered. Yeah.
LNGIUS,
If I have a
LNG,
One
LNG.
by one. Shall I take one by one? Because
Yeah.
another 1 or 2 minutes only I have, then I must ask Reena to present. Yeah.
Yeah, as Dr. Revati is saying, LNG IUD, we can put it off in and tell her to take 0.3 milligram of conjugated equine, and that dose, most of the women tolerate it very well.
Yeah. Any other inputs? Yeah. LNG IUS is an option, maybe, but it is not yet come in evidence. That is what I thought. Anybody has to give me. And Dr. Meeta, is LNG IUS an accepted alternative to this kind of progesterone therapy?
Yeah, we don't. Actually, I think dydrogesterone and progesterones, they have more evidence, but evidence is coming in from levonorgestrone. But when you're looking at the heaviness of the breast, it all depends on the side effects. You have to be very specific about the side effect. And then you be thinking about, whether it's the estrogen component or whether it's progesterone component.
Okay.
Okay. About change in it's very difficult to comment when it is a very general one.
Fine. Okay. And I am just trying to see that if the woman comes back with specific symptoms, can we deliver progesterone in any other way? One input that we can have is a past menstrual history. Yeah. Anything? Yeah. There are women who give past history of severe PMDD, menstrual and premenstrual tension and premenstrual dysphoric disorder. They are the ones who are intolerant to this kind of progesterone, the oral progesterone. And then in them, maybe we need to look at an alternative. That is what I wanted to put in here. And then there are options like, bazidoxifin. There are options like tibolone, or that is what I wanted to know, whether we can prescribe any of them, or we need to convince her to take the same progesterone.
No. It's always good to, change depending on her need. It's always good to change the progesterone or the, the route of administration or the dose.
Yeah. Specifically, if she comes in with intolerance to, because when we give it in a combined way, sometimes when we suppose we give estrogen and followed by progesterone, and she is intolerant to estrogen, then can we look at transdermal? Do you think that transdermal can be a first option in a patient like this? Because some women do not like to take oral hormones, or the risk profile and all, we will come in other prescription. In this patient, actually there was no specific risk for thromboembolism except for advancing age. So transdermal also can be an option, even though there is no direct indication for it. That's what I wanted to know.
Yeah, transdermal can be an indication unless her LDLs are high or her HDL is very low. Then I would still convince her to take the oral estrogen.
Correct. This is the input I needed. That one test which will help us to decide is the lipid profile. So we will be, but because in this case, we do not suspect dyslipidemia because of her BMI. So probably we are looking at suitability of the oral medication because transdermal estrogen is quite expensive. So cost effectiveness lies with oral medication even today. Cost effectiveness, because remember that MHT needs to be taken for a longer duration of time than other medications that we are thinking of. Just one word about COC, and then I hand over to Reena because I would prefer to her to complete, and then I can give the complete prescription. The COC, and one thing which I forgot to tell here is that suppose the woman comes back with some kind of vaginal bleeding. Suppose she has had severe premenstrual dysphoric disorder, we know that any other type of progesterone will help. If oral doesn't causes more symptoms, we can go for LNG IUS, as everyone said. That is a reasonable option, though evidence is still lacking there. But if we continue the same treatment, the oral medication, she comes back on oral MHT, she comes back after a few months and says that there is some vaginal bleeding, then what should we do in such cases? Because if there is a history of PMDD, it also means that probably her need for progesterone may be higher. All right, so that in them especially, is there any risk of the endometrium escaping the protection of progesterone in spite of the recommended doses? Do they need more monitoring for endometrium if they start bleeding? Yeah.
Is the bleeding within 3 months or 6 months or later? What is the duration after which she comes
around
with
that
it?
time. Around that time. So, for example, she comes in 6 months and says that there is some breakthrough bleeding in spite of her taking the medication. Then suppose we do a transvaginal and we see that there is endometrial hyperplasia. How should we go about it now? And what about future MHT for her? Yeah.
Any patient, I think, coming with a any patient coming with a endometrial hyperplasia, specifically whether she's on MST or not, and
We deal with her as
is there,
endometrial
we have to
hyperplasia.
take a
Yeah,
biopsy.
correct. We have to take a
But OPD
biopsy.
biopsy.
Even OPD people biopsy is enough. She doesn't need an hysteroscopy in
Yeah.
the first go.
Correct.
The people biopsies, many a time we get the report, hormone-induced desensitization-like reaction. This biopsy report comes to us when we take the biopsy.
Correct. I was just trying to say here that if they come in with some bleeding, it needs to be evaluated, and sometimes it is a thin endometrium and it is a breakthrough genuinely. At other times, it is possible that the dosage of progesterone has not been enough in that particular patient, and she has developed some thickening of the endometrium under the effect of estrogen. She requires evaluation. And I would like further discussion on this particular case, further MHT. What should be done? It comes as a simple hyperplasia and we treat, but eventually she will have symptoms again. She will have symptoms again. We do have patients who have endometrial problem and symptoms. So how to go about it?
Higher dose of
Shobha, if
progesterone will be required.
Higher dose of progesterone can
Shobha,
be
if we, yes, please go ahead.
Dr. Sudha, please tell.
If we go for endometrial protection and we see the studies, continuous combined, everyday progesterone is the best one for endometrial because atrophy is there. The only thing is, provided the dose is adequate.
That is
Herein we are giving her a very, minimal dose.
minimal dose, yes.
Minimal dose. The route is better. If you give it for less than, 10 days, no endometrial protection. It has to be for more than 12 or 14 days. And if it is a continuous, that is the best one. But the dose has to be more. So we can increase the dose in this case.
Correct. So I can go for 1 milligram plus 10 milligram dydrogesterone.
Yes.
Somehow, Sushobha, if we, the cost factor which you told initially, many times these patients forget to take that progesterone in time.
Exactly.
Not the exact time. So I never give them. If there's a cost factor, I say it is better not to give or put the LNG IUCD.
So we need to check on the compliance also. We need to check on the compliance also. Otherwise, we may have a more problem than we started with initially. So the compliance, the exact way that they have to take, everything has to be told to them, and that is how it will go. Now, Padmaja, you can bring in Dr. Reena, and after that we'll finish with the final slide of the prescription. Thank
Yeah.
you.
So
Yeah.
till now we've been listening about the medications, and now no treatment is complete, as Dr. Rama Vaidya showed us right at the beginning, without the rest of the supporting treatment, because medications are part of the job. And we have Dr. Reena Srivastava, who's ex-professor HOD at BRD Medical College, Gorakhpur, UP. She's been the president of the UP chapter of OB-GYN Gorakhpur Menopausal Society. And she's been with ICOG. She's organized numerous conferences, authored many books, and she's received many felicitations. I'm not taking much time, Dr. Reena.
Thank you so much. Thank you.
And the newly elected chairperson for the Clinical Research Committee.
Thank you.
Congratulations, madam.
Thank you, everybody.
Yeah.
Well, we have got less of time, so I'll be a
that's
bit
right.
fast.
Yes.
I'm just going to share. Is it seen?
Yes. Full
Okay,
screen.
so I'll go. Yeah, I'm just going for full screen. So till now we have done all with this patient who is 52 years old, and she's just having hot flushes and there are no comorbidities. She's not obese. But then this type of every patient who is in menopause transition or has attained menopause just needs the therapeutic lifestyle management and supportive therapy. Maybe she needs hormones or not, but this patient definitely needs. And I would be talking on the supportive therapy in the form of diet, exercise, spirituality, smoking, drinking, micronutrients, and uh, lifestyle. So coming on to the diet, we have to mind food because as Hippocrates says, be thy food, be thy medicine. And that is very true. If the food is well coordinated, nutritious, balanced, so many diseases go off. And that's true for menopause. We have to take care of a balanced and nutritious diet. And it should contain, as you see, the cereals and millets, that is 270 grams. Every meal should have fruit. Throughout the day we should have at least one serving of fruits of 100 grams, having colored fruits. I'm not going to detail them, you all know. Then vegetables, 3 servings of 100 grams each, having all colored green leafy vegetables. Then pulses, if she is non-vegetarian, then 60 grams in 2 servings. That means evening and morning, both the meals should have pulses. And if she is non-vegetarian, then 30 grams of non-veg one time and pulses on the other time. Milk and milk products, 300 grams per day, according to the taste, be it curd, be it milk, be it buttermilk, be it cheese, whatever she likes. And then 20 grams of sugar, only refined sugars, 20 grams, that comes to about 3 to 4 teaspoons per day. Then fats and oils, they should not be omitted totally. There has to be, somebody speaking. There has to be fats and oils essentially in the form of 20 grams per day.
Just a minute, Reena, just a minute. There is a lot of noise there. If that can, yeah.
So
Dr.
the
Kiran's
fats and
iPad.
oils, is it all off? Okay. So fats and oils we should have in the food for this patient, and 20 grams per day is permitted. Be it cooking, be it choka, be it on the loaf, whatever. It should be only 20 grams, and that comes to around half kg in a month. So that has to be calculated according to the family members. And one more thing, that the oils and fat should be from 2 origins. Suppose mustard oil is being used at one time, the other time another, like groundnut oil or olive oil, because a variety of the fatty acids and PFAS are required, and that will cover all. So every meal throughout the day should have a variety of things. This is the chunk of this is the message that one should not have only roti sabji or dal roti and chawal and sabji. This should not be the thing. All the varieties have to be taken throughout the day, as said. And regarding salt, it has to be less than 5 grams per day. That comes to only 1 teaspoonful, be it cooking, be it using in anything. And so we should avoid table salts, pickles, sprinkling on the salads, all that should be avoided. Sugar, 2 to 3 spoons if required. This patient can have, she's having a BMI of 23, but a lot of refined sugars should be curtailed. Then talking of caffeine, that is very important. People are taking a lot of tea and coffee throughout the day. 200 milligram of caffeine per day is enough. Not more than that should be used. And for that, 2 cups of brewed coffees and 3 cups of instant coffee or tea can be used throughout the day. More than that is going to increase the anxiety, increase the tiredness and depression in a patient. So it should not be consumed. Then talking of chocolate, sweets, carbonated drinks, these all have to be curtailed. They can be taken for taste once in a while, say 15 days or in a month, whatever. Glass of water, that should be around 8 glasses of water in 24 hours. And for water, we have to take care that it should not be taken immediately after meals. It has to be at least 20 to 30 minutes after the meals. Then we come to prescription, right? One more thing in the this thing diet is very important, that this patient is having hot flashes. So soya protein, soya chunks, soya milk, and soya in whatever form, blackberries, cranberries, all these can be used along with the nuts like akhroat and this one. Two pieces of badam and akhroat every day she can use. That is going to help her. And if we use a variety of things in the diet, it is going to cover all the things. Next comes the prescription for exercise. We have to, the lady has to be active. Although she is a lecturer, she is going to college, but she might not be doing an exercise regularly. And 30 minutes of moderate intensity physical activity is required 5 days a week. This we have to counsel her. Exercise should include aerobic, muscle strengthening, breathing exercises, and balance. Mild exercises does not protect bones. As the people say, hum to tohelte hain. It is not going to do. Regular moderate exercises, 90 minutes a week, they will reduce the risk of osteoporosis and protect the bones. Any form of exercises which he is familiar to or which he is doing since beginning, like weight bearing, walking fast, yoga, stair climbing, jogging, dancing, swimming, strength training, breathing exercises. The only precaution is that one should take is that she should take measures not to fall. Then living with menopause needs spirituality, and we should mind the souls with prayer, meditation. We have to be positive, live without expectations. And one more important thing, that if the lady is now menopausal, she has got a lot of, she has been able to do with all her responsibilities, she should continue her hobbies like painting, dancing, singing, going to merry time with friends and clubs, and all that should be continued. The only point is that the eating should be in the way she has to, as just now told. Going to clubs and eating too much is going to disturb her. All the de-stressing things she should take care of, because it is going to go a long way, and it may reduce the menopausal symptoms also. Smoking is a big no-no because it inhibits osteoblast activity and it increases breakdown of exogenous estrogens. Drinking in moderation, like if the person is not in a habit of drinking, she should not start. But if she's already taking, it has to be taken in moderation. And it is said that 1 standard drink per day for a woman is not harmful. It may rather protect the bones also. If it is wine, it should be a red wine. 2 standard drinks can be taken. If it is whiskey, it is high in calorie. Only 1 standard drink is allowed. Coming to calcium, which is very, very important for this age group, and 1200 milligram for adults over 50 years is recommended, but this calcium has to be not as a supplement. It should be from diet plus supplement. And for that, we have to go through a big chart, which is calcium, um, which product is having good calcium, like milk. Buffalo milk is having 520 milligrams in a glass, while cow milk is having only 300. Then Khoya is having 600 in 100 grams, paneer, cheese, all these ragi, all these are good for calcium. And I remember Meeta's one line in some seminar that sesame seed is very good, 15 milligrams of grams of sesame, that is comes to 2 tablespoonful. If it is taken per day, then it covers around 600 to 650 milligrams of calcium per day. So, do laddu uske til ke in season is very good for calcium supplement. And at a time, not more than 500 milligram of calcium should be consumed, because our body will not be able to take it. Vitamin D is very important, although most of the Indians are deficient into it. And the sources like sunlight, nobody is going to the sun, although going into it for 30 minutes with the face, neck, upper arm and hands without any clothes between 10 a.m. to 3 p.m. is good for it. And this gives around 350 to 490 international units of vitamin D. But nobody is going to the sun these days, what I feel. And food sources, that is milk, curd, non-vegetarian fish, fatty fish, cheese, butter, all these are good with vitamin D. And vitamin D is very, very important because calcium will not be absorbed. And the daily allowance is said to be 600 to 800 international unit per day. And we have to calculate of our own for this patient also, whether she's going to sun, whether she's taking non-veg diet, whether she's taking milk properly. All that will give you the answer. And it's always better to go for a test of 25 hydroxyvitamin D if patient is having any symptoms. And accordingly, we should replenish the stores in the form of, if she is deficient, 60,000 international unit once a week for 8 weeks, and then maintenance therapy in the form of 60,000 once a month. And before going to give a big thank you, my thanks to dear Dr. Ragini, Dr. Anita, Dr. Shobha for including me here. And my seniors sitting over here, I think Madam Rama Vaidya is there. My regards to her, my regards to Durusha ma'am, and my namaste to all the previous presidents, Meeta, Sudha, everybody who is here to help us out in this e-prescription workshop. Thank you so much.
I am audible, no? Padmaja, I am audible?
Yes, Dr. Shubha, you're audible.
Yeah. I'll just share and finish off my job, and then we'll have a open house discussion. I'll just finish what I completed that time. Okay, so I have to be here. Yeah. Okay, so just give me a few minutes. So this is the patient for whom we attempted to write prescription today. And I just wanted to mention here that all her reports were normal, in the sense she did not have any positive, any of the abnormalities in the tests that Ragini outlined. A mammogram was normal, lipid profile, endocrine profile was normal. So we have a woman, the patient preference may be oral medication here.
सारा कागज लेके आ जाओ.
Uterus is present. She has quite severe symptoms and she has no comorbidities at present. So these questions have been answered. So I write a prescription for continuous MHT as we just now discussed. And this can happen, this can be given for 3 to 6 months. A revisit, you can plan a revisit anytime you want. You can tell her about any of the warning symptoms if you wish. For example, we can tell her if she has any symptom side effects of gastrointestinal side effects, or she has any feeling of heaviness, or she has any other like headache, or she has any swelling of isolated limb, whatever you want to tell her, the warning signs which you feel should be important. Now these are very low dose hormones to cause any major side effect. That also we must remember. The safety profile of MHT has been well established today. So if we just tell her any features of intolerance, any unusual symptoms, you come back. Because remember, this woman is not a diabetic or a hypertensive. And we give her the rest of the prescription, which we are going to discuss in the next slide, depending on what Reena also has spoken. So in a woman who is suppose she says that oral medication is difficult, we have dealt with those options already. And we also have discussed whether transdermal can be used or LNG IUS can be used. And if she comes back with bleeding, we know what is the direction we have to take. So most of the kind of, troubleshooting we have to some extent discussed. The only one thing which I wanted to say, that if a contraindication crops up at any visit, then we may have to kind of rethink about continuing the MHT. For example, suddenly we find that she has become hypertensive in a future, then in any of the future visits, then we may have to take a call on this, and we shall certainly discuss women with hypertension in the upcoming modules, because NCTs are so common for us. So as my friend Ragini very correctly pointed out, that we begin with counseling. We tell her about the medication. We tell her actually that we have ruled out contraindications, and then we are giving you this prescription. We have done all her profiling. And we tell her the value of regularly getting her sugars and thyroid screening, lipid profile, at least annually or semi-annually, depending on the risk factor. In this patient, an annual screen may be all right. Except for the blood pressure. The blood pressure needs more frequent monitoring when a woman is on any kind of estrogen or any kind of hormonal therapy. So maybe once in 3 months, blood pressure testing, or even a monthly. Today, very good digital devices are available. Now, I think menopause prescription should have very essentially the lifestyle modification. Most menopausal women become sedentary because in Indian communities, they think advancing age is for more rest, and they cannot be more wrong. It is for more activity. So as Reena pointed out very nicely, exercise, we do recommend 10,000 steps per day, or at least 4,000-5,000 steps per day, 5 times a week. Resistance training also has to be told to them. Now this woman has a relatively low BMI. I would like to protect her against, we are doing our bit by giving her MHT, but I would like to protect her against further bone weakening by telling her about resistance training also, and teach her about resistance bands also. Protein diet, Reena has excellently brought out all the ways why we have to emphasize on these products, because Indian diets are poor in all these. They're poor in cheese and milk products. But then we need to tell her about curtailing on the other nose. The sugar, salt, and polished rice should be reduced. Please focus on polished rice, because this causes vitamin B1 deficiency and neurological consequences, especially in older people. Fresh fruit should be more than 1/3 of the plate. Reena has told about soya products, etc., sesame, legumes. Calcium also, she said. Just wanted to add that the supplementation part should be at least 1 gram. It can be divided into 500 milligrams twice daily. And the citrate one is more bioavailable. The carbonate one is better tolerated. So we need to take a call on that. But any product which she tolerates well and which delivers 1 gram per day is good. And a dietary should be assured. So with the milk products, it will come. Vitamin D, 1,000 international units twice daily. That is 2,000 units per day. Maybe a little more, but then that is the pregnancy recommendation, 2,000 units per day. For menopausal women, maybe 750 to 1,000 units. I would like to have expert opinion on the vitamin D per day. Slightly conflicting reports from everywhere. And then of course she gets the MHT prescription. And then we need to tackle immunizations, because as women get older, they must understand that annual influenza vaccination is necessary. They are past the age of HPV vaccination, but there are, if they have had chicken pox in the past, they need to get shingles. If they become a diabetic, then immunization is mandatory. And then most importantly, they have to pick up a hobby and they have to increase the friend circle. Never forget this. What I have, of course, not added here is they should always keep their intimate sexual life alive, never allow it to die down. Women who refuse hormones will deal with it again, no time today. Self help tips for those who have very, very severe vasomotor symptoms. Avoid sudden temperature changes. And Reena already said avoid coffee, alcohol, smoking also. Spicy food might trigger a vasovagal attack. Exercise, increase in exercise will protect her against some of the attacks at least. Relaxation techniques, layered clothing, cooling devices, etc., and very absorptive wear during the day and especially during the night. So I shall stop here and then I will open for discussion. Let us have some concluding comments from all the experts, and then today's discussion, I think we have done to some extent. Yeah.
Ma'am, may I ask a question?
Yes, Amrita.
Yeah, ma'am. Regarding the biopsy, which has to be taken for the patients who are having bleeding after the continuous MHT or the hormone replacement therapy they are taking, don't we need to stop the hormone therapy for a while and recheck and then do the biopsy? Or yes, ma'am?
See, when we talk of endometrial biopsy in patients on menopausal hormonal therapy, if they are on sequential hormonal therapy, then we need to know the ultrasonographic, the person who is doing the ultrasonography, he needs to know what period of, what type of estrogen or progesterone she is taking at what point of time. The best biopsy is to be after the withdrawal bleeding. That means after the withdrawal of the progestrogens and after the bleeding, after the menstruation, of withdrawal of progestogens, that time the best biopsy is taken. And I think more than 8 or 9 millimeter is the cutoff point. The guidelines say that if the patient is on continuous combined therapy, the endometrium is so thin that it behaves like a normal endometrium, and you might not do it. This is the Donald guidelines from Donald Sonography Book 2018. But now this patient is not on the adequate hormonal therapy. It is not on the adequate dose of progestogens. So in her case, I think you are very right. We need to stop her therapy for some time. And then I think Dr. Meeta can throw light on this.
Yeah. So the question is when to do the endometrial biopsy if
On MHT.
On MHT if she has a bleed. I think the guidelines are very, very clear in saying that, your ultrasound plays a very important role as a first step because it's very easily accessible. So once it is, say, less than 3 or 4 mm in a continuous combined regime, and there are very clear cutoffs. So you also have to put that whole woman in perspective in the clinic, in your particular clinic, because that each woman, if she is a high risk for endometrial cancer, say she has got obesity or she has some family history of cancer earlier, then probably you would be more aggressive about, even with the 3 mm, at least do a hysteroscopy guided biopsy is the gold standard now. If that's not available, of course, the second is the pickle biopsy, because you're also going to see the atrophy when you're putting in. Sometimes you have these cystic atrophies which are there, different types which will not be seen if you're just doing the blind biopsy. So having said that, yes, so endometrial biopsy plays a role, but at the first shot, you need not worry if it is only 3 mm. If it is 6 mm or more, then you go for the biopsy. And 3 mm, you can reassure her, especially when you're also looking at the Doppler and this thing, and then wait for another episode. But she has repeated episode. Then of course the biopsy is mandatory. So you here also, You need to individualize that particular woman.
Yes,
for
ma'am.
your,
Yeah, the question
But
will be whether we need to change anything in the prescription. Maybe
no, ma'am.
that is
My
another thing.
my
No,
concern was that
Yeah.
won't we, if we do it immediately, won't we get the changes what were already there because of the hormones in the endometrium? We
No,
are
that
here
is our
to
question.
we are here to
Yeah,
find out
exactly.
whether she is having malignancy or not. So we need to be, I mean, give her time,
No.
a break
Samajh gayi.
regarding.
I
Yes,
think
ma'am.
Amrita is relating this to a situation in the reproductive age group where we kind of
Not correct.
do a
No,
biopsy
no.
after all the hormonal influences are removed. See, Amrita, before starting, we make sure that there is nothing, right? We make sure that there is nothing. So then when we start from ground zero, we know that there is no malignancy in the endometrium. Of that, we are very sure. So when we start, then after a few months, maybe 3 months, 4 months, she comes back with bleeding. Then we evaluate and we find a thin endometrium, as Meeta said, and I think Sudha also agrees on that. We need not kind of biopsy if it's a very thin endometrium, but we need not stop the hormone completely and wait and then do. The patient requires some kind of information and solution at that time. So we can reassure her if it is thin, but if it is 6 millimeter and more, it is possible that our dosage of progesterone is not adequate. But then, with such a short hormone therapy of 6 months or so, I don't think things will manifest
Yeah.
so fast, right?
Okay, ma'am.
And
So
I
we
Thank you.
need
so
to
I
give
can
time.
add,
We need to give time. Yeah.
can I add one point, Shobha? I
Yeah.
think the counseling,
Mm.
especially when before you start the continuous combined regime, she's
Mm.
just 1 year, 3 months postmenopausal. So the
Correct.
chances of having this irregular bleeding is much higher than what you would be when you start, say, about 2 to 3
Later on.
years
Correct.
later.
Mm. Mm.
So
Yeah. Correct.
that itself will make a whole lot of difference in the, but
Mm.
you don't have to stop the therapy.
Correct. Why?
And
Why?
also and also within 3 months or even 4 months, that will be a settling phase, in which time they may be having slight bleeding, which we need not worry much about, and then
We can
frighten the
counsel them,
patient
and that
also.
is one. Yeah.
Yeah.
But the evaluation is necessary. That's all. Evaluation and reassurance is necessary. But I don't think we need to change, because, but just make sure that the progesterone given is adequate. In case we are going for a separate formulations like combined CEE plus progesterone, we will not be sure if the progesterone is being taken well. Then we need to check on the compliance. But otherwise, if it is
Shobha, there is a British Menopause Society guideline 2024. They say that within 3 months, just assure. 3 to 6
yes,
months, you can counsel
that's
them
why
or
I
change
said
the
4
hormone.
months
After six
onwards.
months, you have to evaluate.
Correct. 4 months
Then
onwards, I
only
would say.
evaluate. Okay.
Why we need to be slightly different is our women are very afraid of taking hormones. So they require evaluation reassurance. They require it in a very big measure. They're very afraid. For contraception, they are so worried. MHT
Ma'am,
also, they are very worried. Yeah.
ma'am, can I ask a question?
Yeah.
Can we give this estrogen gel for some time to such patients?
Yeah, correct. That is one thing which I did not bring into the prescription, because we were giving orally. Yeah.
Because
No,
she
but
has
what are you
hot
asking?
flashes.
Acha, acha. No, I don't think VMS can be dealt well with vaginal. In fact, when we treat vaginal symptoms with, dryness, etc., with local estrogen, and they develop VMS, there is a recommendation that we must start systemic as well. So it does not really work. So vasomotor symptoms will not settle with vaginal route of estrogen, especially of this severity. They do require systemic they require. If you are not wanting to give them oral, you should seriously consider transdermal. Yeah.
Okay. Thank you.
Someone was asking in
Thank you,
the
ma'am.
chat box, Facilitate. Where can we start that? But it is not available now.
There was a question in the chat box regarding why don't we start with the venlafaxine and all before jumping to the MST.
Yeah. Yeah, I wanted to, yeah, I would like the expert and then I would like to say not. Where is the question?
So, ma'am, there are many salts available, flavons, black cohosh, and
No,
now
kuch effective nahi. No. Black cohosh was found to be no effect. Evidence is there. I think we did a very good
Patient is
session
having
where
such a severe symptom, we can't go for those things. But we can
no,
start with the non-hormonal pharmacological treatment.
won't be enough.
Sudha ji, Gita ji.
Meeta
Yes,
and
yes,
Sudha
we
will
do have non-pharmacological where we find some contraindications. We find non-acceptance with menopausal hormonal therapy. We have FDA approved paroxetine, that is 7.5 milligram. That is FDA approved. We have 10 milligram of the tablet. Then we have gabapentin, which is, many of my patients, they initially start with gabapentin and they do very well with gabapentin.
Very well.
I think these two drugs I have tried myself on my many patients.
So, ma'am,
I wanted to say something. Yeah.
paroxetine is an antidepressant, if I'm not mistaken.
Yeah. They are
Yes, it
centrally
is.
acting drugs. Yes.
Yeah, they are centrally acting. It is antidepressant, but this is the only
gabapentin is a
FDA
very good medicine. Very,
No,
very
GABA.
good.
I'm not talking of gabapentin. I'm talking of paroxetine.
Yes,
No.
this is
Yeah, paroxetine.
this is the only FDA approved non-hormonal treatment for vasomotor symptoms.
Okay.
Dr. Meeta.
Yeah. And for how long we can give this paroxetine, madam?
I think that
Three.
so they have not shown in and no guidelines, but then you call the patient after 3 months, after 6 months,
Yes, we
and
can
then you
give
see
for
the
3 months
response.
and they are giving good
Doesn't
results.
work.
Minimum they require 3 months.
Ma'am,
Gita
how
ji,
much? 20
your
milligram?
comment, your expert comment.
20 milligram
Yeah.
or less?
7.5 is
Okay.
the approved dose, but we do not have 7.5 in India. We have only 10 milligram.
Okay.
Correct.
So
We
10
don't have.
milligram per day.
Yes.
Okay. Yeah. Thank you, ma'am.
Can I have input from Meeta on this?
Yeah.
Whether it can be preferred to MHT?
No. See, unless there is a contraindication or the woman
Correct. Unless there is a contraindication. Yes.
or the woman is just, she's just not willing to
wanting.
take. As
Yes.
some women
Yes.
who say, I will do anything else but hormones. So you
Correct.
try to give them all the literature, try to convince them, but some of them will not get convinced because of some bad stories they would have heard.
Yeah.
So
Yeah.
then we might think of non-hormonal, and like very rightly said, your gabapentin and paroxetine, duloxetine. So I think all the available ones you there also you can tailor according to the need of that particular woman. Some of them, the most of them are anxiolytics. So you also have to remember, but doses are very smaller dose compared to the bigger, the larger doses which are generally given for anxiolytics. So and it's generally not
I needed
very
to.
long.
One more question from my side.
Yeah.
Any time people ask this
Ragini, can
question
I put in? एक बार मैं बोल सकती क्या इसके बारे में?
बोलिए बिल्कुल
हाँ. So I just wanted to bring in one perspective which I think most of us know in our minds, but we have not been able to express. Is now I think there is good evidence today that menopause hormone therapy is not for femininity forever. It actually reduces all-cause mortality. Don't we know that, all of us? I mean, there is good evidence, right? So whenever there is a deficiency like this, I mean, the symptoms of severe hot flushes, is it not an indication by nature that the woman is requiring estrogen?
Absolutely.
And if we don't give it in time, she is not going to have a healthy older age for several reasons,
You're losing the
So,
opportunity.
correct. So, it is important to offer MHT first. It is important to offer it first. So, if you are saying that you don't want to prescribe hormones, you yourself are not wanting to prescribe hormones. So, that is what we wanted to change through these workshops. We wanted you to feel enabled to prescribe hormones. We wanted you to feel convinced for prescribing hormones. So, you please offer her first MHT, because in this case it is indicated.
Yeah. Shobha, that is the
totally agree with Shobha, because
platinum sentence of the prescription module.
Because VMS is an indication that woman is going to have a more cardiac
Yes.
problem in the
Yeah,
older age.
maybe. Yeah, we
And
must think about that. Yeah.
second thing, why the woman is having a more cardiac problem in the older age, because she's deprived of the estrogen. So we have to give the estrogen.
We
Totally
must
agree.
not offer alternative therapy before offering hormone therapy,
Yes, yeah.
because we
That's
should
totally
not
agree.
easily get led, because the moment she said, madam, hormones will it not cause more problems? So we should not kind of step back and say, okay, I'll give you something else. So first feel convinced that you have done enough homework, you have seen the patient, you know that she is not going to land up in trouble. At least give her some treatment for 1 year and see how it goes. I don't think anything will go wrong. Wrong. And then somebody has put a question: how long to continue? I have written up to 60 years, but with constant revisit. So that is what the evidence says. Maximum 10 years. She's 52 years. So definitely it is within 10 years if we give for 8 years. But then again, that will be a decision to be taken every year. Revisit to the decision. Ragini, please, you conclude now, because I don't think we'll finish.
Just one more question.
Ma'am, one question
because
can I ask?
many a time it comes.
Can I ask?
This question is, Mitaji, specifically to you. 36-year-old woman comes in the OPD with a vasomotor symptom. She wants a contraception also. Her FSH is in a normal range. She is not POI. Should we start MST or put her on the COC?
36 years.
26 years, need contraception, and she's not POI, vasomotor symptom.
Coincidentally, Ragini, I have this young girl of 24, 25 years, exactly what you're saying. Hot flushes and excessive sweating. And FSH, estradiol, everything are normal. But these are not the candidates for hormone therapy, because that is not the cause of your flushes. First, before saying anything, we have to do an extensive evaluation to see why she's getting hot flushes, and sometimes you'll be surprised that you will unearth secondary medical causes. But for this particular girl whom I had seen last week, there was nothing. So the main problem was, then her mother very slowly told me she has got severe anxiety symptoms.
Correct.
Severe anxiety goes into episodes of anxiety, and that's so the sympathetic and parasympathetic system, they have a problem, and that leads to the hot flushes. And then very slowly the girl, after 2-3 consultations, I realized the girl said, my mama and my nani and everybody, the minute they step out of the bathroom, they're full in sweat. So it's a genetic predisposition of the nexus. So hot flush has its origin in the anxiety, and the sweating was totally unrelated. So your hormones are not going to help. You should not be giving them hormones.
Good. Very good
That's why
input.
I wanted this question to be
I
put
think
up.
we'll.
Can I ask one question, Dr. Ragini?
That is the last. That is the last
Can I ask
question.
one question?
Sabha,
Can I
one
ask
mini
one
question.
Any relation of thyroid with the hot flushes in 62-year-old?
Yeah, it could be hyperthyroidism. You have to.
No, hypothyroidism.
Hyperthyroid.
Not hypothyroid. Not hypothyroid.
Hypothyroid on
thyrotoxicosis.
Hypothyroid on medication, controlled, and severe hot flushes at the age of 52.
It is menopausal. It is menopausal. It is not to do with thyroid. You are already treating the thyroid. No.
One question to Dr. Reena. Does whey protein exaggerate hot flush? Whey protein. Whey proteins.
Whey proteins, but
Does it
there
exaggerate the
is
hot
not
flushes?
much evidence to say about it. There is not much evidence to say about it. But first class proteins having lot of all the amino acids should be is the requirement, and vegetable diet is not having all the amino acids. So a variety of cereals and the millets have to be
Madam,
taken.
before we close, do we need
Yeah.
TPS for all cases? There's one question I think that needs answering.
Yes, we need.
Done.
Yeah.
That's it.
We're done. Please conclude.
Shobhaji, I am not concluding. We will meet again next month on the first Wednesday, and we will not concluding even in the next month. We will conclude at the end.
Thank you.
So
Thank you very much.
Thank you all the participants. You keep your questions ready. Put them in the chat box.
Thank you, everybody.
Answered. Thank you.
Please motivate.
And
people to
before we
join
conclude, we thank both all the seniors, Dr. Anita Shah Of course, Ragini, you take the vote of thanks. I will just request
Hey, you can
Dr.
take.
Meeta and no, you do. Dr. Meeta and Dr. Sudha, if possible, to join in for every module. It will be such a blessing for us. Thank you.
They will join.
Just one last word. I
Official
fully agree with
thanks.
you, Dr. Shobha, that this module, whatever you are, doing, this is for us to convince ourselves. Believe
Yes.
me, there is not even a single patient who will say no to MHT, not in my experience, if convinced properly. We
If
have to convince ourselves because it is our fear that if we give alternate therapies, there will be no harm to the patient. So it
Correct.
is to convince ourselves.
Yes.
Patients are coming, they are asking for the hormones. They say कि America, England में तो ये right left bio identical hormone मिल रहे हैं. Why don't you people write?
Not identical.
Anyhow, so we concluded today with a vote of thanks, official vote of thanks as a Secretary General of IMS. So I will, first of all, I will thank a person who has worked a lot. That is Paresh ji. Thank you so much, Paresh. Your hard work has shown. We have many people has joined. Then I will start the ceremonial thanks to our founder president, Madam Vaidya, and our past president, Dr. Durusha, for sparing their time and giving their pearl of wisdom to us. Meeta ji and Sudha ji, you are the backbone of the whole program. Please be there always. And my sincere thanks to Dr. Anita, who has never said no to anything. If anything will bring, Nanam ye karna hai, to अच्छा चलो कर लो.
She deserves an applause. She deserves an applause.
She needs an applause.
You all deserve applause. You are doing a lot of hard work.
Shobha, this is my really close to my heart, this topic, and I met you and we have able to do it. Thank you so much. And my thanks to Padmaja and Lakshmi. I never asked them to be part of it and they said yes. And very nicely, Padmaja has conducted the whole thing. And my all char coordinator, please, zonal coordinator, do join in every program. And Rinaji is only there. And then we have from West Zone, Anna Chauhan. North Zone, we have Jyoti Bhaskar. And East Zone, Rina ji. And South Zone, Shobha कौन था? भूल गई मैं.
रेवती मैडम.
रेवती मैडम, yes.
रेवती मैडम है और पद्मजा और लक्ष्मी हमारे साथ कोऑर्डिनेटर्स हैं.
रेवती मैडम को तो मैं ये जो कोऑर्डिनेटर वाले उस पे सोच नहीं पा रही थी ना, इसलिए. Thank you so much and thank
you everyone.
All those 31 people who has joined and one person, Naisargi Patel, she has asked many questions. So you really deserve a clap. A person who is really reading it properly, and Amrita and everyone who has joined today, and Sonika who has made such a wonderful.
More than 56 have joined by YouTube link.
Yes. So, and my message to all who is listening and who is not listening, we will send again the link. The people who has unnecessary joined and not joined, and they, because of them, people are who want to join and join on the YouTube.
Exactly.
This is not fair. Please don't join if you don't want to be. So thank you so much. फिर मिलेंगे, but this time the first Wednesday of the month. है ना Shobha?
Yeah. Whatever is
4 to 5:30 only.
Whatever is decided, we should stick to it. Yeah.
Excellent job.
Thank
by
you,
the
everybody.
team. Excellent job.
Thank you.
All of you.
Thank you very much.
Thank you so much.
Bye.
Thank
Hope
you.
we do better. We do better and better.
Yeah. we'll do better.
Done the best.
Thank you.
Bye bye. Paresh ji,